Welcome to Women's Healthcare, the OBGYN podcast. I'm your host, Alexa Konomos, along with Dr. Perugini from Health Central Women's Care. So, Dr. Perugini, we're going to talk about long-standing birth control and contraception. And I know there's a lot of choices out there, and it's a really big decision for a lot of women. So, if I were to come to you as a patient, what's the first question that you would ask me?
So the first question I'm going to ask you is, are you planning pregnancy at this point? And, then I tell them the answer to that question is going to depend on what you want for contraception. You have to ask yourself, how devastated would I be to be pregnant, and what am I willing to do in order to achieve that? So for example, a young woman just going off to college, it'd be pretty devastating to become pregnant at that point. On the other hand, if I have a young woman who's married, she already has one baby, they're planning another, maybe they're thinking they want to put it off 6 months from now, that's a totally different approach to their contraception. So usually what I'm going to do is I'm going to go through all your different options as far as contraception. I kind of break them into groups. So the first obviously is just your barrier methods, your condoms, your spermicides. And again, condoms are going to give you some sexually transmitted disease protection. So depending upon where you're at and with your relationships, that's very important. Maybe not such an important factor for a woman who's married in a monogamous relationship. The next group is basically the hormonal methods. They work by inhibiting ovulation. The one everybody knows, birth control pills, right? Mm-hmm. So it functions by basically suppressing your ovaries. The ones that maybe people don't know so much about, Depo-Provera, which is an every 3-month shot, and then Nexplanon, which is one of the long-acting reversible contraceptives. And then the last group are the IUDs, and there's basically 2 different types of IUDs on the market: the copper-containing IUD and the progestin-containing IUDs. So I think I kind of go with that, and most people kind of have a little bit of thought on which direction they go, but I tend to go into more detail on each one. There's lots of different options out there, and it varies from lady to lady. So if I have somebody, like I said, we're gonna talk, somebody in their 20s, not ready to have babies, not maybe in a regular monogamous relationship, but not thinking children anytime soon. The long-acting reversible contraceptives, are great. It just makes life easy. So if we were going to talk about those 2, or that group, the first one I'd talk about would be the Nexplanon, which is a little bar. It gets placed, just underneath the skin in your arm. It's going to release low-dose progestin, and that low-dose progestin is going to inhibit ovulation. The beauty is that little implant is placed. It works for 3 years.
For 3 years?
3 years. Wow. You don't have to do anything with it. You don't have to go renew it. It's there, it's working. And not only that, it's super effective. It's the most effective form of reversible contraception on the market today. So if you take 1,000 women, how many are going to get pregnant? Less than 1 in a period of a year. So that's absolutely no worries about it. There is no estrogen in it, so with traditional birth control pills that have estrogen in it, they can slightly increase your blood pressure. No issues there with the progestin. It can slightly increase your risk for blood clots. Again, no estrogen, no problems with that. It is a hormone contraceptive. So I tell patients, anybody who uses any hormones, if they've ever looked at the big fact sheet of possible side effects, it's about this long. The majority of patients tolerate it well, don't have mood changes, don't have weight changes, don't have acne changes. They just get great contraception with it. But there are some people who will get some moods, some weight gain, some more acne. The downside to progestin-only methods is that you don't have regular periods. So I would look at you and say, don't expect to have your once a month normal menstrual cycle if you're using the Nexplanon. About, 60% of people with Nexplanon are going to have no bleeding or very, very infrequent bleeding.
So it's infrequent. It's not going to be where a couple of weeks have gone by and then, oh, surprise, you're coming my period again.
Right, in 60%. Now, the other, 40% may have this sort of on again, off again. I'm spotting a little bit, now I'm bleeding. When they looked at the studies, if you looked at a woman and you measured how much blood she lost in her normal menstrual cycle throughout the year, and then you compared that with what women who are on Nexplanon, it's less. So while you may have maybe a little more frequent bleeding, it's not heavy. It's not like you're on those 2 or 3 days of that heavy bleeding of your period.
Because that can be really tough for a lot of women. I mean, it almost feels like sometimes, not like life stops, but it's a lot to manage.
It's a lot to manage. And again, that's one of the trade-offs for for a method that's so effective, and really so low risk and easy. Most of my young women don't really have any problems with the insertion. They put a little, numb it up a little bit. They make a little nick, less than, the space between my fingers, and then they just slide that little bar in there. It's less than 2 inches long. You can feel it, but just like if you look at my hands, you can feel the bones in my hand and the tendons in my hand. So you can feel it there, and you want to be able to feel it. That's how we get it out. And let's say at the end of your 3 years, you're like, I've loved this, I'm still not ready. They can take that bar out, put another one right back in.
And is there any kind of anything you have to do after the bar is put in? Is it effective immediately, or does it take some time to sort of penetrate your system and work?
It depends on when you have it placed. We, as a group, like to place them. If you place it within the first couple days of your menstrual cycle starting, it's effective immediately. If you place it later than that, then you need to wait at least 7 days afterwards before you can count on its effectiveness. So we routinely will put them in right after you start your menses. We call people up, we get them worked in, and we get it placed.
That's pretty amazing. And even if it is the 7 days, that really is not that long to wait to have that kind of protection.
Right.
Let's talk about another form, and that is Mirena.
Right.
How would you compare that one and its effectiveness?
Okay, so Mirena is in the IUDs, and the Mirena is still very, very effective. If you look at basically effectiveness, you're going to get, for the Nexplanon, if you look at a year, you put 1,000 women place a Nexplanon, you're going to have maybe one girl get pregnant.
So
one woman.
Just like the other one we talked about, it's 1 in 1,000.
Right. If you go with a copper IUD, you're maybe more like 3 or 4. If you're talking birth control pills, you're up probably, 90.
90 on birth control pills.
And the reason for that is we're not talking theoretical effectiveness. You've got to put in the real world. I forgot my pills. I forgot to pick them up. I got messed up in my office. My doctor's office didn't call them in, and so they weren't there when I needed to. My insurance company changed, and they, I had to go through the mail order, and it didn't get in the mail. Or you're just like me and you just can't remember to take the things. Or I've got other medicines that are interacting with them. So lots of things can happen with them, and that's the beauty in the long-acting forms is they're there and they're working. So the IUDs are the other type of long-acting contraception.
And Mirena, when we talk about long-acting, are we talking about 3 years or 5 years?
So the Mirena IUD is good for 5 years. You place it again, if you place it right within a couple days of your menstrual cycle, it's effective immediately. You don't have any downtime with it. It tends, as I said, to thin that endometrial lining. How it works, because I think there's a lot of confusion out there among the public as far as how this IUD works. It has the progestin in, and the progestin hormone is just local. It's not suppressing your ovaries. So your ovaries will continue to function. You'll have the same hormones that you had before. So unlike birth control pills where people say, I felt really hormonal, I didn't feel like myself, the Mirena after time, and I'm going to come back and I'll talk about that a little bit, your ovaries should be functioning the way your ovaries are going to function. So you'll have the same hormones that you did. But that progestin gives a lot of local effect. And so it thickens up that cervical mucus so the sperm can't find their way through the cervical mucus, up through the uterus, out to the fallopian tube where fertilization takes place.
Hence the prevention there. How does that, is that also inserted in the arm?
No, the Mirena is a T-shaped device. It's placed through the cervix and then into the uterus. And it has a little string that will be in your vagina. You could put your finger in your vagina and feel that string. You're not actually going to feel the IUD itself because it's in the uterus.
Okay, I've got a question. I'm going to get real personal here.
Okay.
Okay, if you're talking about the string,
right?
For women who during their cycles use
right.
tampons, is there any kind
no,
of
there's no problem with that.
I had to ask.
And that's totally fine. I mean, everybody's like, okay.
And how does that work?
Right. And a lot of patients will go, oh, you're going to put that, put that up in there. And I'm like going, yeah, it's a little uncomfortable when you place it. Most of my patients are able to tolerate it just fine. We have them take some Advil before they come in. And then once it's placed, I tell people, that day you may be a little achy, a little crampy, maybe a little Advil, but that's it. Then, after a couple of days, you shouldn't really feel any different. I tell people, if you've worn a tampon before, right? Yeah. No problems with that. Don't necessarily feel that it's there, right? You shouldn't feel the IUD.
And we're women, we're used to taking Advil and feeling crampy.
Right.
So it's just, what's one more day?
Right.
I'm curious to know, for women who are some of your younger patients who are perhaps teenagers or in college and who haven't had a baby yet, or someone like me who's had 3 babies, would it be a better fit for someone like me? Is there, in terms of the size of my uterus, for a uterus that's had children versus one that hasn't?
Right. So the thing about the IUDs is there's actually 4 different progestin IUDs that are on the market. Mirena was the first one, not actually the very first progestin IUD, but of the new progestin IUDs, it was the first one that came out. The company Bayer that makes Mirena then came out with a smaller version called Skyla. And the beauty in Skyla is really designed for young women who have never had babies because their uterus is a little bit smaller. They've never had anything come out of their uterus, so the insertion can be a little more uncomfortable. So the Skyla is a little shorter.
It's like a little sister.
A little sister. Little shorter, little narrower, little less hormone. It goes in so much easier. And so when I had young women who never had any babies, I talk to them about it, and I usually say, look, I think the Skyla is a better option for you. But since that time, they've come out with Kyleena. The downside to Skyla was it was only good for 3 years. So you had to have it replaced after 3 years. And I don't want to harp and make it sound like that insertion is terrible. But let's be honest. If we don't have to have anything done to us, it's better, So they came out with Kyleena, same size as the Skyla, still small, but it's good for 5 years. And I've had patients who look at me, when they're getting ready to have their IUD replaced, and they go, look, I tell myself, 1 day of pain for 5 years of contraception, totally worth it.
Perspective, right?
Right. I mean, it's all
relative,
and it really works great. So the Skyla is the one we tend to go for more in my patients who have never had babies before. It's not got as much progestin, so you don't get as much suppression of the menstrual flow. But still, a lot of women, it's not uncommon if you've got a progestin IUD to have no bleeding at all.
Wow.
And they love that.
Oh, absolutely. I mean, that's such an incredible bonus. Now, I know that a lot of women want to know mood swings, weight gain on this one.
Okay. So
and acne, by the way.
Right. Acne, so again, I'm a full disclosure girl. I'm going to tell you it all. When you first placed an IUD, as I said, it doesn't suppress your ovaries. You're going to get a lot of local effect. And the analogy I give people is I go, look, everybody's taken Benadryl. How do you feel when you take Benadryl, right? You get dry eyes, dry mouth, sleepy. But if you put a little Benadryl cream right here, you get a lot of the itch gone. You're not going to get the dry eyes, the dry mouth. Now, it's not going to help this itch. It's not going to help that itch, but it'll work real well here. So it's sort of the same thing. If you're taking oral contraceptive pills, these are going everywhere. They're systemic. If you're using a progestin IUD, you get a lot of local effect without that systemic effect. So in the long run, your hormones are going to be what your hormones are going to be. But initially, when I first place it, the first couple months, you may feel like, okay, am I taking hormones? Because this is making me feel a little weird. The acne, sure, you can get about 10% of patients perhaps may get a little bit of worsening of their acne. But again, you have to kind of look and say, did I have bad acne and I went on the pill and my acne got better because of the pill? Well, now you're back to your baseline hormones.
Interesting. So I'm curious to know if you're on an antibiotic, unlike the birth control pill, it's not a problem.
Not a problem. I mean, you don't have to worry about other medications.
Right.
So again, that's the beauty in these long-acting reversible contraceptives. It's there. It's working. You don't have to worry about, I forgot to take it. I didn't pick it up. I'm taking something else. It's working.
Now, I have to ask about extreme case scenario, because when I'm in the doctor's office, I know that's what I ask, and I bet you get asked this a lot too. What happens if you're the 1 in 1,000 that gets pregnant with this? What do you do then?
Okay.
Or with the device at least.
Okay. So because pregnancy is so infrequent, one, you have to make sure that you're pregnant in your uterus. You don't have a tubal pregnancy. Okay. And I don't want to make it sound like tubal pregnancies are more common in an IUD, because again, if you get 90 ladies pregnant on the pill and you go 1 in 100 is going to have a tubal pregnancy, then that's one person. You look at that same 1,000 ladies, you go, I only got 1 lady pregnant, and only half of those are going to be in the uterus. It's actually less, but there, if you look at the overall percentage, it's higher for a tubal pregnancy. You need to make sure that you don't have a tubal pregnancy. If you have an intrauterine pregnancy, then you've got to decide, okay, do we leave the IUD in? Do we take the IUD out? Okay, and I'm assuming that you want to continue your pregnancy. Okay, so let's just make that assumption. You're planning on continuing your pregnancy. If you can see the IUD they recommend removing the IUD. It could.
Your doctor removes it.
Your doctor removes it. You can't. You know. Yeah.
Don't pull it.
Don't. Well, I mean, I'm going to tell you, these strings feel like a little bit of like fishing line. They're thin, and I don't know about you, but I'm not going to be able to get my fingers up there and grab hold of that and pull that out. So, your IUD, your doctor would remove the IUD. You may have a little bit of bleeding. You could miscarry in response to that, but a large percentage of ladies do not. The problem with leaving it in is you've got a little bit increased risk of developing an infection during your pregnancy.
Okay. Now, speaking of other matters related to this, what about STDs, HIV? Do these work to prevent that?
No.
Or is that totally separate?
Totally separate. Again, the only thing that's necessarily going to decrease your STD risk are condoms. And so again, in counseling my patients, if I've got young women, I start the conversation with, no matter what else you choose, you need to use condoms. Condoms, to protect yourself.
You can't say enough. You have to get your partner tested. Right. You have to get yourself tested. It's just a courtesy. When we're talking about Mirena, what happens if you have a vaginal infection or a yeast infection? Does placement have to stop? And then once it's in, how soon is it effective?
So same thing as with the implant. You can place them at any time during your cycle. And I think our group still pretty much insert them right after you start your menses, in which case they're effective immediately. If you've got an active infection going on, you don't want to place the IUD at that time, just because you are going from your vagina up into your uterus, which is a sterile place. And so we try to do that as sterilely as we possibly can. We put your speculum on. We're going to clean off your cervix a little bit and then slide that right up in there. But if you've got infection going on at that time, if let's say you come in, you don't realize you have an infection, you're not really having any symptoms, and then we test you and you do have an infection, we just treat you for that. We don't have to remove the IUD. The odds that you're going to get an infection with your IUD placement is very small. It can happen, but it's very small. And the majority of patients, I tell people, really, if you're going to get an STD, and I tell my young women this, you don't get gonorrhea from your IUD. You get gonorrhea from somebody else. So you need to protect yourself as far as for those types of infections.
So, Dr. Perugini, when your patients come in, if I had this, and this, again, this lasts for 5 years, what happens during your yearly checkups and you're getting your pap smears, or do you have to come in to get the placement checked every year, or is it once it's in there, it's just in there?
So that's a good question. So what I do, when I have a patient who comes in and we place her IUD, if it goes in easy, felt like it went in fine, typically we'll have our patients come back in about 6 weeks just to check a sonogram, make sure it's still in the same place, because you can get, about, a couple % of people are you're just going to have enough cramping that's going to push the IUD out. And so we check at 6 weeks to make sure it's still in the same place. We also see how they're doing. Are they having weird problems with their bleeding? Are they having problems with their moods? And we tell people, you run fever or anything like that, please call us. But we do see them back at 6 weeks. If the insertion is difficult in any way, shape, or form, we check it right then. One of the complications with IUDs is that you're sliding this device. Like I said, if this is the uterus, you're going up through the cervix and you're placing it right here. You can put that IUD right through the uterus. And it's uncommon, but it is one of the complications. So typically when you have a perforation where the IUD is placed all the way through the uterus, people are going to have usually some pain with that. So like I said, if it doesn't go in easy, people seem to have more pain than what I would anticipate. I usually check a sono right then. If I have patients who have their IUD placed, their Mirena placed, they're not having much bleeding at all. They're like, maybe have a little spotting every couple months. And then they call me and they go, wow, I'm really having a whole lot more bleeding. I typically tell them, come on in, let's check and see. Otherwise, I'm seeing my patients annually. Certainly if anybody feels like they've got pregnancy symptoms or anything like that, we tell them to check a pregnancy test. But I don't do sonos every year as far as for placement if they're not having any different symptoms.
Now, Dr. Perugini, if there's a perforation, placing it in, what happens? Does it heal naturally once it's removed, or does there have to be some kind of assistance?
Well, so if you have a patient who comes to see you, and I certainly have had this happen. I had a patient whose daughter had an IUD placed, and she called and she said, she had a lot of pain with it. And, then we did a sonogram. And she was also a sonotech. So she said, I sonoed my daughter, and the IUD's not in the uterus. I said, okay. So we got an x-ray, and sure enough, the IUD's not in the uterus. It's in her abdomen. She needed to have a surgery. So we did a laparoscopy and retrieved the IUD and removed it. Typically, your uterus is a muscle. So if the hole in the uterus heals itself, but you got to remove the IUD.
Right. And that's what the laparoscope.
Yeah.
Got it. So another scenario, let's say that this is one of your patients who is not a teenager, but has actually had a baby.
Right.
And they want to get back onto birth control after they've given birth. How soon can they do that?
So, if you read the literature, okay, you can, right after the baby's born, put an IUD up in the uterus. I'm going to be honest with you and tell you I've never done that. I don't plan to do that. Your odds that the IUD is going to be expelled, because you've had a baby before, you have bleeding after delivery, your uterus is healing. About 1 in 10 to 1 in 4 will actually expel that IUD. So I don't do it at that time. I usually have my patients wait till about somewhere between 6 and 10 weeks postpartum and then place it. And the reason for that is your uterus, again, you've had a baby before, your uterus is big and then it clamps down. So right after, the first couple weeks after delivery, your uterus is very soft. And so you go, how do you know how far to put that IUD in? And I would tell people it's kind of like if you had your coffee cup and you were putting your spoon in there, you hit the wall, except if your uterus is very soft, it's easy to go right through. So your odds for having a perforation are much, much higher if you try to place that IUD really very quickly after delivery.
Here's another scenario, Dr. Perugini. Ovarian cysts. Can these, by any chance, create a follicle that would create an ovarian cyst? Is there any risk of that at all?
So with the progestin IUDs, again, cysts are common, and that goes back to that little statement that I made early on, where you sort of get this feel of, I've got this progestin. So it can kind of interact a little with your ovaries those first, several months that you have your IUD placed. And so it's not uncommon to see cysts. For example, when I bring my young ladies back to recheck their IUD placement at 6 weeks, it's not uncommon to see a cyst there. They're usually small. The patients don't usually even know that they're there. It's just because we looked with the sonogram, and they almost always resolve. And if you say almost always, I can't think of the last patient that I had that it didn't go away, that we had to do anything with it. And I can't remember the last patient that I had who came in and said I had really severe pain because of a large cyst that ruptured. So having some follicular cysts right after or around the time of insertion, common, but they resolve, no worries.
Okay, that's good to know. When you compare this one to the last one we talked about, are they apples and oranges, or is there one that you
I think they're
tend to use more?
Well, they're apples and oranges, again, because it's personal preference. I get some young women who look and go, I really feel uncomfortable. I'm afraid of the IUD insertion. So that having this placed underneath in their arm, easy. I have some patients who say, I didn't like the hormonal effects with the next one on. I wanted to go with an IUD. So they're just different as far as, which one patients want, but they're both great forms of contraception. The one we haven't talked about is the copper IUD. So I don't use it as much because the copper IUD, just like the progestin IUDs, are all T-shaped. They all go up inside the uterus. It doesn't have any hormones at all in it. And I've had several patients who are very sensitive to the hormones and say, I don't like any of that hormonal feel. I tried this one, I tried that one, and this has absolutely no hormones in it at all. It's effective for 10 years. People always kind of go 10 years. And I'm like, you can have it removed whenever you want.
10 years.
10 years. So for that lady who's done with having her babies, say you're 30 and you're like, I'm done. I don't want any more. Or you're 35. I'm done. I don't want any more. You can have that placed and it's there. It functions. It works great. It does tend to make your cycles a little bit heavier, but again, no hormones, and people like it for that reason.
So if we're talking 10 years, what about the effectiveness? We've talked about the two others, that if you had a group of 1,000 women, one might get pregnant. If you take that same group of 1,000, how does that stack up?
So maybe two. So still way more effective than oral contraceptive pills, just because of user error.
Is it placed the same way?
It's placed the same way as the progestin IUDs. Yes, through the cervix up into the top of the uterus.
Okay, so the same rules would apply, that it's best to come in when it's during your period. You might be a little bit achy for the first day.
Right.
And no hormones. Now, here's a really personal question. I think that a lot of women wonder when we're talking about IUDs. Will their partner feel the IUD during intercourse?
Most don't. I'll occasionally get some patients, and I tell them I tend to leave my strings long because it's easy to remove them that way. I tell them, look, what happens is with those strings that are there, your natural cervical mucus tends to coat those strings so that your partner's not going to mind them. But if they do, we can always trim the strings.
Okay. Also, FDA approved?
FDA approved.
FDA approved. And what if, again, you're going back to, let's say you're a new mom, maybe it's going to be your last baby, but you're a nursing mom and you want to get on contraception.
Right.
Can you take it as a nursing mom?
Well, all of the progestin-only methods are okay to use with breastfeeding. So you wouldn't go back to traditional oral contraceptive pills because of the estrogen content can suppress your milk supply. The progestin methods are all okay to use with breastfeeding. So yes.
So that's safe.
Safe.
And again, you did mention heavier periods, but will they be more frequent?
Typically, the copper IUD doesn't change your menstrual timing. So if you're somebody who goes every 4 weeks, you probably should still go every 4 weeks. If you're somebody who has the crazy cycles, I bleed every 2 weeks, I bleed every 6, then I'm 3 weeks, then I'm 4 weeks, you may still do that exact same thing because it's your ovaries that are driving when you bleed.
Does it take the body a little bit of time to get used to whatever kind of IUD or insertion you're using? Does it take the body some time? Does the body sort of adapt to it?
In some ways, as I said, that cervical mucus is going to coat that string, so that's going to take, probably a couple weeks as far as with that. That initial cramping, usually a day or two. The progestin IUD, like I said, the first couple months you may feel that, some systemic progestin, but then that should resolve. The copper IUD, there's no hormones anywhere, anytime. So
And still so effective.
Which
I think a lot of people might think, oh, how effective can it be
Right.
if there's no hormones?
Right. But what happens is that the copper inhibits the sperm.
So it's the copper.
Right. So it's the copper in it that inhibits the sperm, also changes that mucus. So I tell people a lot of things got to go right for you to be pregnant, right? And so if you mess up just a couple things, it's going to keep that from happening.
Right. And a lot of people realize even if everything goes right, it's still
Right.
not necessarily always easy
That's
to get
exactly.
pregnant. But that's a different podcast.
That's a different podcast. I think we've got somebody else who will talk about that.
Right. If I think we've done that podcast. What if someone decides that, oh, you know what, we've changed our mind, we do want children. Is it as easy as coming to you to remove it?
All of them are easy, So, for example, if you've got a IUD, you come in, we pull it out, and I look at you and go, look, you could conceive tonight. I don't want you to conceive tonight, but you could conceive
That
tonight.
quickly?
That quickly. It's gone.
No,
But as I said, those don't inhibit your ovaries, so you have been ovulating. So it's kind of like we rip the condom off. Go for it.
I see.
So again, most people won't, but I have had people conceive within 2 weeks of having their IUD. I don't usually recommend that. All the hormone, everything's out. I usually say, listen, wait till you have your next natural cycle and then go for it. And again, your cycle should return right away because that hormone's gone.
If I was on traditional birth control pills, I remember this when we were doing our family planning, thinking, I've got to be off these birth control pills for a while for me to get pregnant. First of all, is that true? And secondly, how long does it take if you're on the traditional pills, typically to kind of free your body to get pregnant?
So really, if you're taking traditional birth control pills, if you stop taking them today, they're really out of your system within a couple days. The catch is
Just a couple days.
Just a couple days, but your ovary's been suppressed. So you've got to get that ovary to come back and start to ovulate again. So I tell patients, it's not months. You can conceive within 2 weeks of stopping your pills. Then again, you may not. But I usually, again, tell patients, let yourself have at least one natural cycle to let that lining in your uterus kind of come back.
Yeah, the body kind of needs to rest and
Yes.
and I guess reset itself.
Right. But watch out. Because like I said, if you're looking at me going, oh my gosh, my wedding is 2 months from now or 3 months from now, and you're like, oh no, my fitting's not going to be okay. I need to,
I remember those days of worrying about,
Yeah.
those little, planning your periods around your wedding.
Or I'm on my way to Europe in 2
Right.
months, and oh my gosh, I don't want to be vomiting all the way through my early first trimester. So be aware, the effectiveness is gone usually within a couple days.
But it's so great to know that there are so many options out there. I mean, I remember when, I think all of us remember that time when we had to make those decisions.
Right.
And
Correct.
at times we felt that those, the options were so limited.
Absolutely. And especially, as you said, if you're somebody who says, I just don't do well on pills,
Right. It's a lot to manage.
Whether I can't remember to take them or I turn into Sybil. I mean, it just, it's one or the other. So,
is there a question that that your patients typically ask? What would be the most frequently asked question about contraception? Or perhaps a misnomer or a misconception?
I would say probably the number one question I get on IUDs is how painful is it going to be? And as I said, the majority of my patients really tolerate it just fine. The second thing is that there's a lot of people just really have a lot of preconceived ideas about IUDs and how dangerous they are. And I think a lot of that, goes back to, probably many years now when they had the Dalcon Shield, which was probably the worst IUD ever. I mean, just a design flaw by all all considerations. And so there were a lot of women who were actually really harmed with that IUD. And that's why for a number of years there were no IUDs available in the United States, even though the other IUDs that were out there worked fine.
A lot of times I think we let our fear rule us,
Absolutely.
or we listen to, what happened maybe to our mother's generation.
Right, absolutely.
And we tend to make our decisions based on that. But really, when you are coming to your OBGYN,
Right.
it's important to recognize, I think, that there's really a partnership here.
Right.
You've essentially got your partner for life in your doctor.
Right. Well, you like to think that. I like to believe that patients come in and I try to give them, this is the information out there, and say, you need to make your decision based on what's going to be best for you. But I'm going to present all the options. And that's just who I am and how I do things. I don't really try to push people one way or another. I can push people one way or another if I feel like they absolutely need to do something because of other medical conditions. But lots of methods out there, and you just have to be comfortable with it. And it's funny because I get a lot of patients who weren't receptive to certain things until their sister, their girlfriend, their roommate tried it and seemed to do okay with it.
The word of mouth is a
Right.
very powerful
Absolutely.
thing, is it not?
Absolutely.
Is there anything else that you would like to add that perhaps we haven't covered?
I think the only no, I think talk with your doctors. There's lots of stuff on the internet, and there's things on the internet can be misleading, but I don't think it's a bad thing. Information is power.
Yeah.
So
Just as long as you take that, I think we, in many ways, advocate for ourselves by getting on the
Absolutely.
internet, but then you have that conversation with your doctor.
Absolutely. And again, I would look at people and say, if you're using a particular contraception and you think something's not right, call.
Yeah.
And keep calling.
And listen to your
keep
gut.
calling. I mean, because you need to get things that are not right for you addressed.
Well, it has been it really has been an education. I was going to say, I'm probably like many women. I didn't know much about some of the other forms of birth control. So
Right.
thank you so much,
You're
Dr.
welcome.
Perugini. Thank you.
It was great talking with you.
You too.
Thanks.
For more information about Dr. Perugini and long-acting reversible contraception, you can visit the website at healthcentralobgyn.com. Also on social media, Twitter, Facebook, Instagram. The handle is @HealthCentralTX.